Module 9 is over GI disorders. So first we're going to talk about assessment. So first for an assessment, we can ask questions. So what exactly is the problem? How long has it been going on? What are the specific symptoms? We can ask all of the PQRST type questions. We can ask questions about the child's normal stool pattern. Are they having diarrhea? Are they having constipation? Has anything changed from their norm? Has anything changed from their normal eating pattern? Have they been eating something different that they haven't been eating normally? What's the family history? Is there any family history of things like IBS or colon cancer? We can ask so many questions about so many different things that can be going on with the child. Like, do they have blood in their stool? Are they vomiting? Do they just have pain? Are they bloated? Things like that. When we are inspecting the child's abdomen, or in this case, really their entire body, what is their body position? Do they feel or do they appear relaxed and comfortable, or are they laying down sort of in the fetal position, like with their legs drawn up towards their chest? Do they appear like they're in pain? Are they holding their belly? What's the abdominal shape and contour? Does it appear to be distended or protuberant? Is it flat? Is it rounded? Or is it scaphoid? And what is the condition of the skin on the abdomen? Do they have any distended veins or anything like that? Next, we would auscultate. So we want to hear normal active bowel sounds, which are sounds of normal peristalsis. So if we hear hyperactive bowel sounds, that could be a sign of many different things, but commonly like gastroenteritis, do they have some sort of GI bug that's causing them to have diarrhea or vomiting? Or it could be something like lactose intolerance. If we hear high-pitched, loud, tinkling rushes, those are sometimes indicative of something that's obstructive. So do they have a bowel obstruction, which we'll talk about in a little bit in more detail. If we listen for 5 minutes in each quadrant, which yes, takes a really long period of time, and there is no sound, that could indicate a paralytic ileus, which basically just means that the bowel is not moving anything along, specifically here in the ileal region. But basically, nothing is moving through the bowels at this point, so the patient is sort of like severely constipated. Can become a problem if it persists, but can be sort of normal after some instances like surgery with anesthesia. And we probably aren't going to percuss, but if we did, we would want to hear tympany over the stomach, the drum-like sound. We will probably palpate, so we want to feel for tenderness. Also, are there any lumps, or is the patient guarding like they are in pain? The first disorder we're going to talk about is cleft lip and palate. So this one's a little different than the other ones we're going to talk about because it is a craniofacial deformity. So it's a deformity that occurs early in pregnancy, usually around the 7th to 12th week of pregnancy. It can involve the soft and hard palate, the nose, the nasal septum, and the maxillary processes. The cause is usually unknown, but it may have a genetic component and sometimes will go along with some syndromes. It's also linked to folic acid intake, and if the mother was drinking during pregnancy and smoking and certain medications during pregnancy. So cleft lip and cleft palate can occur either together or alone. So if you're looking at the pictures on this slide, you can see that it ranges in severity. Here, there's not really a picture of a cleft palate. It's kind of hard to see because it's inside the mouth. So these are mostly just showing you pictures of cleft lips. But it can vary in degree of severity from barely being able to see anything at all, like on the microform one on the left, all the way to the picture on the right, where it's a complete cleft lip and palate, where you can see the deformity is much more severe. But what a cleft lip is basically the lip is not forming properly in that 7th to 12th week pregnancy, and it sort of creates this large slit that can extend all the way up to the nose. And as you can see there, some of the nostrils can sometimes be affected and be deformed from it. The cleft palate is basically going to be, you could think of it as a hole in the roof of the baby's mouth. So again, you can't really see a picture of it on here on the slide, but it can be a problem for things like feeding. So those are not going to be as apparent when the baby is born, and it's not going to be able to necessarily be seen on ultrasound. So this is one of the reasons why, if you thought it was weird where I said to stick a gloved finger in the baby's mouth to assess their suck, well, at that same time, you can be palpating the roof of their mouth to see if they have a cleft palate, because that's something you are going to want to know. Cleft lip is more common than cleft palate, but like I said, they can occur together. The incidence of it is higher in Asians, Latinos, and Native Americans, and it is higher in boys. So the cleft lip is usually repaired around 2 to 3 months. They may need later revisions, usually by plastics, just for the look of it. The cleft palate is usually repaired around 6 to 12 months and may require a second surgery. So these babies may need several surgeries to repair this. But the baby can live with both a cleft lip and palate. They may just have some problems. So you may see babies that are older that haven't been repaired yet for whatever reason, but these are just the normal repair times. So interventions. So until it does get repaired, the infant may need speech therapy for feeding difficulties. So since if they do have a cleft lip, the baby isn't going to be able to latch normally either onto a breast or a bottle. So sometimes, depending on the severity of the cleft lip, they may need a special bottle system. So this picture of this baby drinking out of this bottle, it's called a Haberman bottle. Basically, it has this specialized giant nipple at the end, as you can see where that person's thumb is, that it helps the baby take the milk in a little bit easier because they can't create the vacuum that babies normally make with their lips because of the cleft. We also want to monitor for things like aspiration. So if the baby does have a cleft palate especially, they can very easily aspirate milk through the cleft palate up into their nose and then down into their lungs. So usually we need to be very careful when we're feeding them and make sure that they are not aspirating. They may have to have swallow studies. We want to monitor for ear infections, later speech issues, if they are getting it repaired later or if they need more than one repair, and later dental issues. When they do go for surgery for the repair, when they come back from the surgery, usually we do have some sort of restraints on them because babies are just going to naturally want to touch their face, and we don't want them to injure where they just had surgery. So a common thing is soft elbow restraints. So the baby can still basically move their forearms around, but they won't be able to move their arms up high enough to reach their face. So just something that's temporary to protect the surgical site. So they're very soft, sort of if you think about the soft restraints that we have for adults, but they're just a little bit smaller and less harsh. They may follow up with several specialties like plastics, oral surgeons, speech therapy, ear, nose, and throat doctors, genetics, audiology, and they may need a social worker or a case manager to help them deal with all these different things. Celiac disease is a disease that most people are probably pretty aware of, but going a little deeper into what it is, it's an immune-mediated systemic disease. It's caused by the ingestion of wheat gluten in genetically susceptible individuals. So gluten is in things like wheat, rye, and barley products. So when people with celiac disease eat gluten, the body mounts an immune response that attacks the small intestine. So these attacks lead to damage on the villi, which are those small finger-like projections in that graphic on the side. So those villi line the small intestine and promote nutrient absorption. So when these villi get damaged, nutrients can't be absorbed properly into the body. So this may occur in conjunction with other immune-mediated sort of diseases. So things like lupus, rheumatoid arthritis, and diabetes. So on assessment, some symptoms that they may have are abdominal bloating, diarrhea, vomiting, weight loss because they aren't absorbing all the nutrients that they need, a lot of gas, small, foul-smelling stool. They could have enamel defects on their teeth, delayed growth and development for a child. A certain type of rash is also common in certain areas of the body, like elbows and knees. Iron deficiency anemia, B12 deficiency, and osteoporosis. So testing-wise, the definitive test to diagnose celiac disease is a biopsy. So there are other sort of oral swabs and blood tests that you can do that say you probably have celiac disease, but the definitive test is getting an endoscopy with a biopsy. And then on biopsy, the person with celiac disease will have increased total immunoglobulin A, or IgA. Interventions for these people are fairly easy, at least on paper. So the main intervention is just doing a gluten-free diet. So there's a lot of gluten-free foods available now, but still I'm sure it is quite difficult when people may be missing certain foods that they love that they can't eat because it's causing them pain. We can consult a dietitian and provide resources to them. And they do need to have regular follow-up with a gastroenterologist. Appendicitis is inflammation of the appendix, which the appendix is a sort of a finger-shaped pouch that projects from your colon on the lower right side of your abdomen. So appendicitis, again, is inflammation of the appendix, but it can lead to perforation or rupture of the appendix. So this is one of the most common disorders that causes a child to have surgery. So on assessment, the signs and symptoms, they're going to have pain in the periumbilical area, which is just anywhere sort of near their belly button. And that pain is going to move to the right lower quadrant. They may have a low fever, nausea and vomiting, laying with their knees bent. They may have rebound pain, which if you remember this from 5th semester, it's when you press down on the abdomen slowly and then release suddenly. They could have pain at McBurney's point, which is just in the right lower quadrant near the hip. They can also have pain when they move their hip in certain ways. So if they internally rotate their hip, they can have pain on passive extension of the hip, which is some of these signs on that left part of the graphic. So usually they do have pretty severe pain, but pain that suddenly resolves is not good. So that may indicate that the appendix has perforated or ruptured. So if you have a patient that's in extreme pain in their right lower quadrant, and then all of a sudden they feel a little bit better and their pain is gone, that means the appendix may have ruptured. Testing, we would do a CBC to look for infection, a UA, an ultrasound or a CT scan, or both to visualize the appendix and confirm appendicitis. Interventions for this, if somebody comes into the ER with these signs and symptoms, we would make them NPO. We would give them an IV for IV hydration and pain medication and prepare them for surgery. So nowadays, the surgery is usually laparoscopic. They would also order antibiotics pre-surgery. There's usually a large overgrowth of bacteria in the appendix when they have appendicitis, so we want to prevent any infection. Gastroesophageal reflux, or GERD for short. So in pediatric GERD, there's immaturity of the lower esophageal sphincter. So this is the sphincter that's at the bottom of your esophagus and at the top of your stomach. So it's immature and it allows retrograde flow of stomach contents back up into the esophagus. So on assessment, the patient could have things like vomiting, a burning sensation if they're old enough to verbalize that, choking, slow weight gain. They could be very irritable and cry after meals, especially babies. Arching during or after meals. So this photo of this baby, it's arching. They could have apnea in newborns and infants. Basically, they have apnea because sometimes the gastric contents are coming up in the back of their throat near their airway, and they sort of just stop breathing to protect their airway. They could have a chronic cough, chronic pneumonia, epigastric pain, mid-sternal discomfort, like chest discomfort, being woken up frequently at night, and a sore throat. So anything that you can think of where if the baby or child is having basically acid come up into the back of their throat and into their mouth, what would happen? Testing, we would do things like weight and length and OFC to see if they are growing appropriately. Since they can have vomiting and they may not want to eat a lot, if they have severe GERD, they could have growth problems. We could also check their stool for occult blood to see if they have any GI bleeding. There is a test called a pH probe, which is sort of, it looks like an NG tube, and it can actually be connected to some special NG tubes that we feed through. But there's a little pH probe at the end of it that sits in the child's stomach, and it basically gives you a readout of the pH of their stomach contents at all time. It honestly doesn't work as well as it sounds. We can have other studies like an esophagram, gastric emptying studies, and endoscopies to look at the esophagus. Interventions. So we want to monitor the child's I&O. So are they getting enough to eat or drink? We could administer medications. So sometimes medications like famotidine or ranitidine are ordered. There are actually surgeries that the child can have for severe cases. The surgery is called a Nissen fundoplication, which basically they make the fundus of the stomach, they sort of modify how it looks to prevent reflux up into the esophagus. Sort of like they make a esophageal sphincter. They sort of wrap the fundus around the esophagus. We also want to monitor their weight closely to make sure that they are growing appropriately. Other easy things that we can do if it's a baby is to hold them upright after they're feeding or elevate the head of bed if they're an older child. So to prevent the acid from coming up, we want to use gravity in our favor and hold them upright after eating. So instead of feeding them and then immediately maybe laying them down in their crib or their bassinet or whatever, literally holding them up for 30 minutes after eating. We can avoid foods that trigger their symptoms. So more for an older child, if there's specific foods, things like orange juice or spicy foods or whatever is specific to the child, of course, we want to avoid those things. For babies, sometimes it's ordered to thicken their feeds, either with oatmeal or rice cereal, or with a special product called Thicket that actually makes it thicker. Sometimes doing small but more frequent feedings is helpful. So say you want the baby to eat 120 milliliters. Instead of having them eat that much, maybe you would have them eat 90 milliliters, but do it every 2 hours instead of every 3 hours. Also, frequent burping is helpful, and sometimes changing the baby's formula to something else if they're on formula to see if the formula they have is maybe a trigger for them. Pyloric stenosis. So pyloric stenosis occurs in babies where the pylorus blocks food from entering the small intestine. So the pylorus is basically a muscular valve that's between the stomach and the small intestine, and it normally holds food in the stomach until it's ready to be moved on to the small intestine, sort of like the next stage. But in pyloric stenosis, the pylorus muscles abnormally thicken and become very large. This blocks food from normally passing to the small intestine. So incidence of this, interestingly enough, boys have a 4-to-1 higher chance over girls of having the disorder, and it is even higher if the mother actually had the disease as an infant as well. The sort of hallmark symptom of pyloric stenosis is extremely forceful projectile vomiting, like literally vomiting that will go across the room. They can have vomiting after each feeding. You can also sometimes observe the peristaltic waves going from left to right before they vomit, depending on the size of the child. They'll usually have poor weight gain from the constant vomiting. Eventually, they can become dehydrated and have a decrease in their chloride levels, and they can have failure to thrive. Testing for this, like on this picture of this baby here, this is called an olive sign. I guess it sort of looks like an olive. So basically, there's this mass that you can sometimes see and you can palpate in the mid-epigastrum area. You can also do an ultrasound to visualize it, an upper GI series, and they may want to test electrolytes to see if they're dehydrated. Interventions for this, they would immediately be made NPO and be given an IV with IV fluids, and they're going to be preparing for surgery to fix the abnormally large pylorus. Volvulus. So a volvulus is an abnormal twisting of a portion of the GI tract, it's usually the intestine, which can impair blood flow. So this abnormal twisting can lead to death and gangrene of the involved segment of the GI tract. It can lead to intestinal obstruction, perforation of the intestine, and peritonitis. Other structures like the stomach, small intestine, cecum, and sigmoid colon are all subject to volvulus. This is sometimes caused by malrotation of the bowel during fetal development, which can predispose the child to a volvulus, which usually has a sudden onset. This can also happen, it can happen in adults as well, sometimes after some sort of GI surgery. Assessment-wise, for babies, this usually occurs in the first 6 months of life. The baby will present with intense crying and pain, pulling up their legs towards their abdomen, abdominal distension, bilious vomiting, so sort of like yellow-green vomiting, tachycardia, and tachypnea. Testing for this, they'll have an upper GI, which is basically what this picture, this radiograph is from, and electrolytes to assess if they're dehydrated or not. Interventions, this one is a surgical emergency where they'll be going to the ER immediately. So of course they need to be NPO, have an IV with IV fluids, and they'll usually have an NG tube to suction. Intussusception. So intussusception occurs when part of the intestine slides into another part of the intestine. It's usually the small intestine that sort of telescopes into the large intestine. right at the joining place of the small and large intestine near the appendix. It doesn't have to be at this spot, but this is the most common spot for it to happen in. So when this sort of telescoping occurs, it cuts off blood supply to the affected portion of the intestine, which can lead to perforation, infection, and necrosis of the bowel tissue. Obviously, when this is telescoped into another section of the bowel, it's going to also block food or fluid or stool from passing through that area and can cause an intestinal obstruction. So it's the most common cause of an intestinal obstruction in kids younger than 3 years old. So this can be caused by something called Meckel's diverticulum, which is basically sort of a genetic anomaly that occurs in some people. Some people it doesn't cause any problems, but it's basically little outpouchings of the intestines that can become infected and cause things like intussusception. Could also be caused by polyps, enlargement of lymph tissue, or sometimes they just don't know what the cause is. On assessment, the child may have sudden drawing up of their legs and crying. They may have vomiting, that's bilious. The pain usually occurs in regular intervals, so it sort of waxes and wanes every 15 to 20 minutes or so. After 12 hours, sort of the hallmark of this disorder is the development of currant jelly stools. So a currant is like a dark red berry. So basically the stool literally looks gelatinous and is sort of dark red, blackish color. It's basically stool that's mixed with blood and mucus. They have increased abdominal distension, fever, peritoneal irritation, so they may have tenderness and guarding of the abdominal area, tachycardia, and elevated white blood cells. So testing can do a ultrasound or a barium enema to visualize the intussusception, and a CBC. Interventions, they'll immediately be NPO, an IV with IV fluids, an NG tube to suction, and they can have surgical correction of the problem. Sometimes actually the barium enema, which is basically, it's an enema, but they have barium in it, which is basically like a contrast fluid, so that you can see certain things on x-ray. So sometimes when they are actually doing the barium enema, it actually corrects the intussusception. So sort of like the pressure of the barium fluid that they're putting in sort of helps draw this intestine out. There's also another procedure called air insufflation, which is sort of like an air enema. So sort of the same sort of thing as the barium enema, or water soluble solution. So basically a water soluble enema also to reduce the intussusception. Necrotizing enterocolitis, or NEC for short, is the death of tissue in the intestine. It occurs most often in premature or chronically ill infants. So sometimes this may happen after an infection or an ischemic event that the baby has. What we worry about most is the intestine perforating and basically spilling the contents into the baby's abdomen. So on assessment, the abdomen is usually very tense feeling and extremely distended. Like you can see in this picture of this baby, its stomach is extremely distended. They may have an increased girth measurement. So frequently for chronically ill babies, we are monitoring their abdominal girth at least once daily, if not more. So we would notice there is an increase in that girth that's not due to weight gain. They may have a large gastric residual after an NG feeding. So like you learned in 5th semester, we check residual usually before we give the next feeding to make sure that there's not a whole lot left in the belly. So for this, it depends on how much the baby is eating, how large the residual is. So I can't give you really a number, but if the number is very high compared to how much the baby is eating, that could be a sign. We could see blood in their stool. They could start acting sort of sick, where they're having periods of apnea. Their blood pressure could start dropping, and they may have poor temperature stability. So, meaning they may be cold when we don't expect them to be cold for any other reason. Testing, so we can test the stool for occult blood to see if what we're seeing in their stool is actually blood, or sometimes it is hidden. A CBC, and an abdominal x-ray so that they can visualize the intestine. So you can see on this x-ray here, the baby's belly does appear very huge. And again, you don't need to interpret x-rays, but you may be able to see here that there is a lot of gas in the abdomen. Interventions, they're going to immediately be NPO to allow their bowel to rest. So they're probably not going to be able to eat for a rather long period of time. So it's extended bowel rest. So usually they're going to need things like TPN and lipids, and not just normal IV fluids because it's going to be an extended period of time. Usually on antibiotics to prevent any sort of infection or treat any that they may already have. If the bowel does unfortunately perforate, or if the intestine is starting to basically necrose, they will need to have surgery to remove that diseased intestine. If they have to take out a large amount of intestine, the baby could be given an ostomy at this point, which, depending on the severity, it may just be a temporary ostomy while the baby's bowel rests for sometimes several months. Or it could be a permanent ostomy as well. Gastroenteritis. So gastroenteritis is sort of a broad term for the onset of diarrhea in the absence of a chronic disease in children or adults. That's usually caused by some sort of virus or bacteria or parasite. So some examples on here: rotavirus, norovirus, E. coli, C. diff, salmonella. There's a bunch of different ones. We don't always normally test for this. It could be like if you've ever had food poisoning yourself, you don't necessarily go to the doctor and they test your stool. They just say it's gastroenteritis, and sort of they're all treated basically the same. So signs and symptoms: the child could have watery diarrhea, abdominal cramping, vomiting, headache, fever, and chills. Their stools could have blood or pus in them. They could also have signs of dehydration if they're having a lot of vomiting and diarrhea. So things like tachycardia, depressed fontanelles or sunken fontanelles in a baby, a lack of tears, especially in a baby, poor skin turgor, lethargy, a decrease in urine output, or fewer wet diapers than normal. The symptoms can last just 1 to 2 days or all the way up to 10 days. Testing, like I said, usually it's just diagnosed by symptoms and an exam. If they suspect something like parasites, then they may test the stool for ova and parasites. They may do a stool culture or a white blood cell count of the stool. You can also do CBC and electrolytes if dehydrated. So interventions, we can start with an oral replacement solution, also called an ORS, or oral salts, sometimes it's called. Basically, you can think of this as like liquid IV packets, but more for hospital use, so they probably don't taste as good. But basically, they have salts in them, so sodium and chloride. Some of them have glucose and potassium as well. But you're going to start with one that's 75 to 90 mEq of sodium per liter every 30 minutes. So this is one you're going to try to use if maybe they just have mild vomiting or they're not vomiting at all. If they are severely dehydrated, So they could be said to have severe dehydration either based on their electrolytes or if their symptoms have been going on for a long period of time. We can start an IV, and then we're going to administer an isotonic solution at 20 milliliters per kilogram. Remember, an isotonic solution is something like sodium chloride, 0.9%. We could also just go ahead and start an IV if the person does have extreme vomiting where we don't think that they're going to be able to keep down the oral replacement solution at all. But we can always start and try with that first. We can also recommend easy to digest foods like the brat diet, which honestly really isn't used that much anymore, but things that are very easy to digest and that are very bland. So things like toast, bananas, not something that is spicy. We want to avoid carbonation. So even though, like, my mother always gave me Sprite when I was sick, the carbonation can actually make some people's GI upset worse because of all the bubbles. We want to avoid things like dairy also, because that can upset people's stomach even more. If the child still wears diapers or pull-ups, we want to monitor for a diaper rash if they are having very bad diarrhea. And we want to try to use hand hygiene both for the parents and for the child to prevent spread if it is something that is contagious. Hirschsprung's disease is a congenital condition that causes blockage of the intestine because of a lack of nerves in the bottom segment of the colon. So these nerves normally allow the muscles and the wall of the intestine to contract and move digested food towards the anus to be eliminated from the body. But with Hirschsprung's disease, these nerves are totally missing, sort of like you can see in this graphic. There's no nerves in a certain portion of the colon or in the rectum. So the patient has some of these symptoms, like failure to pass meconium in the first 24 hours of life with increased abdominal distension. So most babies will pass meconium within the first 24 hours of life. Not all, so this isn't like a definitive measure for it, but also with the increased abdominal distension could be a sign of it. The baby could be constipated from birth. So basically, they could be having no bowel movements no bowel movements more than once a week. So it could be, days in between bowel movements, which is something we wouldn't necessarily expect for a newborn. The stool can be ribbon-like or watery. The child's usually very skinny and has poor weight gain, but they have a very big belly, a protuberant abdomen. They can also have vomiting as well. So diagnostic testing for this, if the provider does a digital examination, so basically with their finger, the baby would have an empty rectum, so no stool in the rectum at all. If they do an abdominal x-ray, it could be visualized sort of in this graphic that the rectum can appear collapsed, and then the colon above the part where there's no nerves can be enlarged. They can also have a barium enema, which does allow more contrast when they're taking an x-ray. And a rectal biopsy is the definitive test. So basically, they take a little piece of tissue from the portion of the colon where that they think may be affected, and basically look at it and can see that there are no nerves in this tissue where they would expect there to be nerves. So interventions for this are usually enemas. So usually we would have to teach the parents how to give an enema to the child to allow them to basically stool on a normal timeline. So they may be doing the enemas until they go for surgery. So they can have surgical removal of the effective section of bowel. So they may need a temporary colostomy at this point to allow for bowel rest. So basically they could remove the colostomy later in life if able. It kind of just depends on the severity of the case. Omphalocele and gastroschisis. So both of these disorders are defects in the abdominal wall that causes part of the GI tract to be outside of the body. So these are very similar yet different. So an omphalocele is where the stomach and intestines are contained within a sac. So there's a sac made of amnio, peritoneum, and Wharton's jelly, which Wharton's jelly is sort of part of the umbilical cord. So everything that's outside of the body is still outside of the body, but it's in this sac. So usually it's the stomach and intestines or just the intestines, but if it's a very large defect, it can also include the liver, spleen, gonads, and bladder. So all of those things can be in the sac. What we worry about with this one is that the sac may rupture in utero. So usually both of these are going to be C-sections for safety. The omphalocele is commonly associated with other anomalies, so things like cardiac defects, neural tube defects, or specific syndromes. Gastroschisis is on the right side of the umbilical cord that affects the stomach and the small and large intestines and rarely the liver. So this one, there is no sac. So whatever organs are outside of the body are literally just like laying on the baby's stomach. So there's pictures of these on the next slide. So this one looks more like the baby was basically like eviscerated in some sort of traumatic accident. But with this one, it's unusual for the baby to have any other defects. So usually it's just the gastroschisis that they have. They don't have syndromes or anything like that. So testing for this, when the baby's still in utero, sometimes they'll have an elevated maternal triple screen, alpha fetoprotein, or the AFP. And it's usually diagnosed on prenatal ultrasound because it's very easy just to see on ultrasound. Sometimes they may recommend an amniocentesis as well. So interventions for this, like I said, C-section, right when they're born, they're made NPO with an OG or an NG tube to decompression, so to suction. Obviously, their intestines and possibly their stomach and other organs are on the outside of their body, so we don't want them eating just yet. We want to place gauze, that's non-adherent gauze, that's soaked in sterile saline to cover the defect. So basically, we don't want any of these structures that are on the outside of the body to dry out. So we get sterile saline and pour it over gauze or basically soak gauze in it and then cover the entire defect with it to keep it moist. They're also going to be on IV antibiotics to prevent infection. So obviously these babies are going to have to go to surgery. It's actually usually not immediately. So there's a picture on the next slide of a baby sort of with their intestines in what we call a silo. So basically the surgeon comes by and they put all the intestines, this is for gastroschisis, inside this sort of plastic, and then it's held up on the top of the baby's bed. Like usually if you think of like the top of a radiant warmer that's turned off, and it basically holds the intestines in this tube, and the surgeon will come around usually every day, maybe every couple days, and push the intestines back in the baby's body little by little, day by day. So usually there's just not enough room basically to put it all back in the baby's body just how it is. And sometimes they do this where they're just very slowly pushing the contents back in the baby's body day by day. The omphalocele, so the one that's in the sac, sometimes it's a little bit smaller than a gastroschisis, and they may be able to correct it with just one surgery immediately, but it sort of just depends. With both of the defects, they may need several surgeries to correct it. So usually these babies are NPO for very, very, very long periods of time, months and months and months without eating. So they're going to have some sort of long-term IV access. like PICC lines or Broviacs, and they're going to be on TPN and lipids for a very, very long period of time. So usually these babies have long-term problems with feeding. They have difficulty feeding. They have difficulty digesting food once they're allowed to eat. They're usually very small and don't grow very well. They also can have liver damage from being on TPN for extended periods of time. Just to describe to you what these pictures are, the picture on the far left is a gastroschisis, so there's no sac. The picture on the bottom right is an omphalocele, so you can see whatever is in this particular sac is enclosed in a sac, sort of protected. And then the picture on the top right is a picture of the baby's intestines in a silo. So that baby has a gastroschisis. I don't know if you can really see, but it's sort of in this clear plastic, and then there is a string that's basically going to the top of the radiant warmer to hold it in that position. Biliary atresia. So biliary atresia is a congenital absence or closure of the major bile ducts that drain bile from the liver. So if you're looking at this graphic over here, any of the structures that have the word duct on them could be affected with biliary atresia. This can result in an inflammatory process that eventually can cause liver damage and cirrhosis of the liver if it's not corrected. So on assessment, the baby would have significant jaundice at 2 weeks of age, an increase in direct bilirubin, which is a lab test that you can do. They have poor absorption of fat and fat-soluble vitamins. So basically, bile can't get to the stomach and digestive system as we would normally like it to. And what bile does is helps absorb fat and helps absorb fat-soluble vitamins. Basically, it gets backed up into the liver, which can cause damage to it. The urine could be dark or sort of tea-colored, pale stools, and an enlarged liver. So testing, we can do liver function tests, so they may have elevated liver function levels. Bilirubin, we can do an ultrasound of the abdomen and the liver biopsy. So interventions for biliary atresia, IV fluids, a low-fat, high-protein diet. Since they aren't absorbing fat-soluble vitamins very well, they may have the supplementation of those vitamins A, D, E, and K. And they may have surgery to basically correct whatever defect they have in their bile ducts. If the initial surgery is unsuccessful, over time, if the liver is damaged, they may need a liver transplant. Failure to thrive, or sometimes just FTT for short, it's defined as a weight for age that is less than the 5th percentile on multiple occasions, or weight deceleration that crosses two major percentile lines on a growth chart. So if you're looking at this growth chart on the slide, if you're looking at the weight one, you can see, especially on that one, a little bit easier than the length, that at the beginning, the child is, it's kind of hard for me to see, but maybe somewhere around like the 40th percentile for weight. And then after a few months, they literally just fall completely off the chart. Same with the length too. It's just a little harder to see because they were already pretty short to start out with. But they literally just are not growing along the growth line that we would want them to follow, or at least stay close to. They literally just fall off the chart. So some symptoms that can go along with this could be things like, of course, poor weight gain, vomiting, food refusal, food fixation, abnormal feeding practices, anticipatory gagging when they're about to eat, irritability, smaller height and OFC measurements, delayed development, and chronic physical problems. So, failure to thrive can be caused by many different things. So, it could be caused by some of the things we already talked about in this lecture, like if maybe they did have an omphalocele when they were born, or maybe they did have a cardiac condition that causes them to not have the endurance to eat. So it can be caused by many different things. It's not just one thing that causes this. And it's not necessarily like anyone's fault, although it could be. So testing for this, measurements, plotting on growth charts, doing a feeding assessment and feeding history, developmental assessment, BMP, checking their electrolytes, screening for related disorders. So sometimes kids will have problems with some of these things, like the food refusal or anticipatory gagging, when they have things like sensory problems, which can go along with things like autism. So it doesn't necessarily even have to be a physical disorder. Interventions, they could need hospitalization if they need immediate intake of fluids and food. So if they're acutely dehydrated or extremely underweight, they may need an NG tube or an IV to give them hydration. We may need a nutritionist referral if they do have some of these things like food fixations or food refusals. There's also feeding clinics and speech therapists that they could go to. Parental education, and then, of course, treat any underlying conditions that, if those were resolved, possibly their weight gain and growth could be resolved as well.